Welcome, everyone. I'm Nalini Pandalangat, Vice President, Community Health and Capacity Building Initiatives at Sherborne Health, and I have the great privilege to oversee Rainbow Health Ontario. My pronouns are she and her. Sherborne Health is a dynamic provider of integrated health services, community programs, and capacity building initiatives that enable people and diverse communities to achieve wellness. As a program of Sherborne Health, RHO, Rainbow Health Ontario, creates opportunities for the healthcare system to better serve 2S LGBTQ communities through training for healthcare and social service providers to be more clinically and culturally competent in their care for their 2S LGBTQ service users, as well as through system change by producing evidence-based print and web resources contributing a 2S LGBTQ health perspective to public policy processes and hosting events like this one today. As we come together today, I would like to start by honoring the land that we are broadcasting from. Sherborne Health is located in the city of Toronto, which is covered by Treaty 13 and belongs to the traditional territories of the Huron-Wendat, Anishinaabe, the Chippewa, the Haudenosaunee, and most recently, the Mississaugas of the Credit. We acknowledge them and any other nations who care for the land. Coming together to do this important work, let us learn from the past in order to create a truly equitable current state and future. Particularly for this event today, let us continue to consider how colonization has affected our understanding of gender and sexuality, and keep the work of reconciliation with Indigenous people centered in our future. Thank you for being with us here today. It is a challenging time to be doing work in 2S LGBTQ health, and the tragic violence last week in Colorado Springs is surely weighing heavily on all of us. It makes the work we are doing even more important. Despite our sadness, we can also celebrate that we've come together today to focus on progress, on positive movement forward, and building towards a future where hate and violence towards 2S LGBTQ people has no place. If this is your first time attending an RHO event, or even your first time being involved in 2S LGBTQ health, welcome. Thank you for finding the space in your schedule and in your hearts and minds to be with us here to learn and share. Today, we all have the great opportunity to learn with the editors and several contributors to the second edition of Caring for LGBTQ2S People. I'm looking forward to listening and learning, and for all of us to integrate our new ideas into our work, whatever that work might be. We all know that putting on an event like this takes a village, and I want to thank the many people who've been part of organizing this event so that all of us could come together. To begin with, thank you to the Rainbow Health Ontario, RHO staff members. They're a small but mighty team of people who brought their unique expertise to planning of this event. In particular, Gail Hinnigan has gone over and beyond to work with so many moving parts to make this event happen. Thank you so much, Gail. Thanks also to the ASL interpreters and French translators for making this event more accessible. And to Dr. Amy Bones, whose work at Sherborne as one of the editors of Caring for LGBTQ2S People and as moderator of this panel discussion is always moving the conversation on 2S LGBTQ health forward. Thanks, Amy. We are also thankful to Ontario Health for being such strong allies in our work and for funding Rainbow Health Ontario. And of course, thank you all again for being here with us today for this event. We have more than 500 registrants for this event today, showing a real thirst for knowledge and a drive for change. Before I introduce our panel moderator, Please join me in welcoming Nicole Tange. Nicole is a mixed-race, two-spirit Indigenous person who is a knowledge keeper on issues of gender and Indigenous knowledge, and a poet, musician, documentary filmmaker, and playwright. They are here to help us start the day in a good way and share some food for thought on the work ahead. Welcome, Nicole.
Thank you much for having me. Pedaske Disnakas Nemitodam. My name is Light Comes Through, and I'm from the Sturgeon clan. Sorry, I'm very close. I'm having technical issues. I'm from the Sturgeon clan and Cree Nation, and I am mixed race. I always make sure to let folks know that. And I've been asked in a really good way to do an opening prayer for you, so that you can travel today in a good way and come together as a community in a good way. So I give thanks for all that is around me. I give thanks for the trees, for being able to breathe, giving us the breath of life. I give thanks for the birds and the ones that come and visit us all the time. The birds are the messengers also. I give thanks for the plant life that helped to nourish us. And I give thanks for the animals, the four-legged, who also help to nourish us and give us clothing and food and substance. And I give thanks for the crawlers and the swimmers. For all of those, we were not able to be here. And I want to give thanks for the fact that we are all interconnected, not only just humans, but also the plant world, the animal world, the flyers, the swimmers, the crawlers. We all come from the same DNA and the same spark of life. I also want to give thanks for the waters, for the waters are one of our sacred medicines and should be treated as such. I give thanks for our medicines, the tobacco, the sage, the cedar, I'm just drawing a blank, and the sweetgrass, I'm sorry. And I also give thanks for all of the spirits that are with us, for our ancestors that walk side by side with us every day and give us the strength to carry on. It's those ancestors who are with us that help us to move through moments where we experience violence, like the Colorado shooting and the bombings of gay bars in the early 80s, of smoke bombs where I experienced that myself. I give thanks that we are able to come together as one mind and one heart. And I give thanks for the ability to be a two-spirited person and give those teachings to the young ones. And I give thanks for the young ones. I also give thanks for our old ones, our elders, our healers, our medicine walkers, the ones who hold ceremony for us. And I give thanks for my life as I see it, and give thanks that it's a ceremony that I walk through every single day. Oh, Jimigwech. And I just want to say some kind words about our communities and that we need each other more than ever. This struggle, this fight, this violence that we keep experiencing is still there, and we're still fighting it. And I will continue to fight it until there is none left. So I say miigwech for having me, miigwech, all my relations.
Thank you very much, Nicole, for that beautiful and heartfelt opening. I have just a few housekeeping notes before we move on to our discussion. A reminder that there is no live chat for attendees, but please use the Q&A function below to ask a question for our panelists. The Q&A portion will be in the second half of the event. This event has captioning as well as ASL interpretation and French translation. Please refer to the instructions in the chat for information regarding captioning and translation. If you're posting on social media about this event today, you can use hashtag RHO in Convo and tag @RainbowHealthON. Now, please join me in welcoming our moderator for today's session, Dr. Amy Bones. Amy has practiced comprehensive primary care as part of the 2S LGBTQ team at Sherborne Health since 2011. Over the past decade, Amy has spearheaded multiple initiatives aimed at expanding the capacity of healthcare providers in caring for 2S LGBTQ patients, including authorship of Sherborne Health's guidelines for gender-affirming primary care with trans and non-binary patients, and the adapted interactive online trans primary care guide. Amy takes an avid interest in medical education, having served as the inaugural faculty lead for 2S LGBTQ Health at the University of Toronto Faculty of Medicine, and currently acting as the university's program director for the 2S LGBTQ Enhanced Skills Residency Program. Again, please join me in welcoming Dr. Bones.
Thank you so much, Nalini, for that introduction, and Nicole for that really lovely opening. I'm so happy to be here and to have the opportunity to have this conversation today. Thank you to RHO for all of the work that went into making this happen. I'm really excited to have the opportunity to talk about this book, Caring for LGBTQ2S People, a clinical guide that was published earlier this year from U of T Press. And really excited to highlight the incredible work that was done by our chapter authors who are going to be on our panel this afternoon. And thanks to you all for joining us as well. We have an incredible number of attendees representing social work, nursing, physicians, other allied health and health administrators, which is really exciting. You're all probably in the middle of a busy day. Many of us are working in a system that is under unprecedented stress. But I'm hoping this event will allow us to just take a breath, relax, and engage in some fulsome conversation about 2S LGBTQ health in Ontario and more broadly across Canada, to look both at how far we've come since the last publication of the first edition of this book in 2003, and also to look what the future could hold in terms of continuing to move the health of our community forward. So take a breath, sit back, perhaps imagine that you have your beverage of choosing, herbal tea, obviously. And without further ado, I will introduce our panelists for this afternoon. I'll start with Zhangwei Benisikwe. Their name translates to Sounding Thunderbird Woman. Their English name is Crystal Hardy. They are a Two-Spirit Anishinaabe nurse practitioner. Zhangwei is a PhD candidate in nursing at Queen's University with a focus on cultural humility in action, using Indigenous autoethnography to explore spiritual self-reflection, and using expressive arts to address compassion fatigue. Zhangwei contributed to the chapter on Indigenous LGBTQ and Two-Spirit health for the book. Next, we have Dr. Jordan Goodrich. Jordan is a lecturer with the Temerty Faculty of Medicine at the University of Toronto, is a family physician working at Sherborne Health, where he has a practice focused in 2S LGBTQ health. He has a strong interest in medical education, and in addition to teaching at the University of Toronto, he teaches elective medical students and residents at Sherborne Health. He leads seminars in transgender health through Rainbow Health Ontario and the Centre for Addiction and Mental Health. Jordan co-authored our chapter on sexual health with our colleague, Dr. Ian Armstrong. Dr. Ed Kucharski is a practicing family physician at the Southeast Toronto Family Health Team, Chief Medical Officer at Casey House Hospital, and former Sherborne Health Medical Director. He has taught about 2S LGBTQ primary care at various medical schools, centers, and conferences, has been widely commended for his contributions to addressing health equity. Ed was recognized by the Change Foundation as one of Ontario's 20 Faces of Change for innovative and patient-centered initiatives to improve cancer screening in 2S LGBTQ newcomer and homeless population. Ed was the co-editor along with myself on this text, and we also co-authored the introduction and a chapter on prevention and screening. Dr. Kwan Nguyen is a clinical lecturer in the Department of Family and Community Medicine at the University of Toronto. As a family physician at Sherborne Health, Dr. Nguyen specializes in 2S LGBTQ primary care with a focus on HIV and gay men's health. As an educator, Dr. Nguyen enjoys teaching and preparing medical trainees to become future 2S LGBTQ allies and advocates in family medicine. Kwang was the author of the chapter on HIV for the text. And last but not least, we have Dr. Sydney Tam. Dr. Tam is a queer, trans, Asian, settler, woman, family physician, University of Toronto lecturer, and emergency room doctor. She has been in practice for over 30 years in Canada and the United States and has overseen many changes in the care of 2S LGBTQ adolescents and adults over the decades. Teaching 2S LGBTQ competent care and anti-oppressive care to medical students and residents is an intrinsic part of her teaching practice. She's received multiple practice quality awards, including the Gay and Lesbian Medical Association Provider of the Year Award. And Sydney contributed the chapter on improving patient-provider relationships and healthcare environments for 2S LGBTQ patients. So without further ado, I'm going to launch into asking our panelists some questions. To get the conversation started, we'll spend about 45 minutes answering a series of questions and engaging in discussion that arises out of these questions. And then we'll move to a Q&A section of our event this afternoon. So I'm going to start with Sydney, who is never at a loss for words. And Sydney, can you tell us a bit about your chapter and the process of writing it? And what were some of the challenges and some of the successes? Can you tell us something you learned from doing this writing? Or if you'd like, any key highlights from the chapter? And then I'll move to ask the others about their chapters the same question. Go ahead, Sydney.
Thanks, Amy. First of all, I can start the thank you to all my fellow panelists for being here. I am in the company of giants in the field. Even though I've been in practice for a long, long time, I think it took a long time for me to establish my expertise, particularly in sort of working with populations. In this case, the 2S LGBTQ population, and from a perspective of deconstructing and possibly dismantling a standard of interaction and relationships between health providers and clients who are 2S LGBTQ identified. So the process has been going on for decades, and I've learned a lot. We really don't have a lot of education built in to anti-oppression, equity, diversity, inclusion in our curriculum. Even now, where we have mandates to include inclusiveness into programs, it really is very slowly becoming part of healthcare culture, in particular allopathic Western medicine. So my chapter is short, and it's because I think it can be overwhelming, and at the same time we're talking about some delicate matters in terms of power and privilege. So I don't really need to be schooling people on how to be humans, and yet what happens in especially medical school, I'll just make an I statement here. I didn't go to nursing school. I didn't go to any other health professional school. We often have learned to deconstruct our humanity to the point where our identity belongs to a medical culture. And with that comes a lot of preconceptions that clients have in terms of authority, my approach has always been to deconstruct that and actually try and dismantle it. So I think that the chapter hopefully reflects some of that, but I kept it to also being rather straightforward and directive. There's examples of forms you can include on your intake, those kinds of things. Realizing the forms themselves are a form of oppression by themselves, forcing someone to fill out a form is as a hurdle to get care. It is a lot of bureaucracy that they have to wade through, and you're asking some very personal questions about people's health. But I think at this point, it's at least a start.
Thanks, Sydney. Yes, your chapter, I would say, is definitely one of the ones that anyone in my life who is not a healthcare provider who has expressed interest in reading the book, I direct them to your chapter. The introduction in your chapter is a place to start, just in terms of how accessible it is and how meaningful it is. Thanks for sharing that with us. I'd like to move on to Zhangwei. I really want to hear what the process of writing the chapter was like for you, Zhangwei, some of the challenges and successes, anything you learned, and any key highlights from the chapter.
Great, thank you, Chimigwech. And yeah, thank you to the elder for the opening. And I'm just really grateful to be here today. Buju, Zhangwei, Benise Kwe, Nishtakaz, Makwado Dem, Benjiti Wabik, Saging, Anishnabek, Ndonjuba, Thunder Bay, Ndoji. So I'm a sounding Thunderbird woman. You can call me Zhangwei. My pronouns are they and she. I'm from the Bear Clan, and my home community is Rocky Bay First Nation, and I live in Thunder Bay. And my chapter focuses on Indigenous, LGBTQ, and Two-Spirit health, and I identify as a Two-Spirit person myself. And so this chapter really focuses on a lot about cultural humility, and I know we talk a lot about that, but when we talk about cultural humility and safety, it's really dismantling that power and privilege, as we were just talking about with Sydney. And so for me, this work was really important because it was really a self-reflection a bit too. And actually in the process of writing this chapter, I understood that I was Two-Spirit. And when I first started, I was like, identified as like cis, hetero, all of this stuff. So, and I just thought it was really interesting the more that I had looked into, Two-Spirit and queer fluidity and all of this stuff, I was like, that's me, right? And I think that's the importance of this book, right? And we talk about it being a clinical guide, which kind of sounds very like, of course, colonial, but I think it really will stand the test of time. And there's just so many stories and so many things, like we can't just blanket statement everyone. And in my chapter, I talk a bit about what being Two-Spirit means to me, but also to other people. But, we can only really know that by asking someone. And I think with all of the work of all the chapters, it gives clinicians and service providers and the general public really some just background information, so you don't have to be afraid to ask questions, right? Or to even identify and say yourself what your pronouns are and things like that, because it makes people feel more included, and the first edition, I think, only had like a page or something that talked about Indigenous and Indigenous ways of knowing and being. So yeah, I'm really grateful. Some of the challenges, of course, was the emotional work going into it. I talk a lot about colonization and really like the colonial violence that a lot of people suffer. And you'll notice that as a thread probably throughout all of the chapters though, right? And so I think it's important that, people read all of the chapters, because it talks to the intersectionality of what's happening and really how institutions right now in healthcare is really policy focused, right? And so we talk about patient-centered care, and the only way we can do that is by addressing the needs of patients. And I think this is a great way to be able to kind of dive into it and learn more. So thank you so much, Miigwech.
Thanks, Zhangwei. We're all really grateful for that contribution, and that personal piece of it that you contributed comes through on the pages. And I'll say for Ed and I, reading and editing it, it was a a sombering chapter to review, but so important. I think, let's see, who should I pick on next? Jordan. Can you tell us a bit about your chapter on sexual health?
Yeah, absolutely. So I co-authored this chapter with my colleague and friend, Dr. Armstrong. One of the challenges was we did it in a relatively short period of time, but I think we both stepped up to the challenge and tried to see what we could do within the time that we had. Basically, as an overview of my chapter, I guess it's mostly split into two main areas. One that's mostly focused on kind of sexual function, sexual experiences, kind of different sexual behaviors. But yeah, trying to focus on some of the positive things that can come out of sexual health and sexuality, as well as talking about, of course, sexual dysfunction, things that we often see as clinicians. And then the other major part of the chapter was focused on different things like sexually transmitted infections, recognizing disparities that may exist between 2S LGBTQ populations and the general or other populations that we compare to. I think when it comes to sexual health in general, I'd probably say that most healthcare professions would probably agree that it's maybe something that's maybe undertaught. Definitely in medical school, I think that it was only a small chunk of what we went through overall, but that sexual health is a really important component for viewing the patient as a holistic person and their overall health and overall health care. So there were challenges that came in terms of and lots of learning about what is and isn't known about sexual health, sexual function and dysfunction, sexual practices, risk, satisfaction, all of that. Unfortunately, in a lot of the populations under the larger 2S LGBTQ umbrella term, there really isn't much evidence or research out there. So we had to pull on sort of what clinical practices are currently and what information we do know that guides our clinical practices, but also recognize areas that require more research, which ends up being a lot of areas. But it was really interesting. I would say that going into the chapter, had a fair amount of knowledge and comfort in terms of diagnosing and managing sexually transmitted infections or STIs, but that I really learned a lot about evaluating an individual's sexual well-being, how to discuss different sexual practices with a patient, recognizing that this is an area of discomfort that a lot of people and patients have. It's often a sensitive part of their experiences, and to speak to a clinician about it can often feel awkward and uncomfortable. So one of the focuses that we wanted to emphasize in the chapter was about how to engage in these conversations and hopefully lay enough foundation that people would feel comfortable having these conversations with their patients.
Thanks, Jordan. I can attest to you and Ian truly rising to the challenge of delivering this chapter under tight constraints with incredible detail. I think it makes sense for us to now move on to Kwan. So same question, Kwan. What can you tell us about how it was to write your chapter? And anything you learned or what you think stands out from it?
So hi, everyone. I'm Kwan Yen. I'm one of the family physicians here at Sherwin, and my pronouns are he and him. First off, I just want to let folks know that I'm much more of a writer than a speaker. And also this deep and seductive voice that I have here isn't my normal voice. It comes from having a toddler going to daycare every day. Anyhow, regarding the challenges and the successes, I think when Amy and Ed first came to me to asked me to write this chapter, I was really excited and then really humbled, but then it kind of sunk in and it was like, what next, right? Because HIV is such a big topic. There's so much written about it. There's guidelines, textbooks, research studies about behavioral interventions, movies written about the social, political aspect of it. And so how do I take this topic that is so important, such a cornerstone of our queer history, compact it into a single solitary chapter? So I found that was quite challenging, but I think I was able to do it, and hopefully readers can see the same. I think another challenge would probably be, I think we tend to see HIV medicine as very specialized, and it is specialized in certain cases, but I think with the newer medications that are out there, I was trying to kind of debunk that myth and try to kind of make it more accessible to primary care. And so I looked at the guidelines and the studies, and then again, I tried to compact that all into one single chapter. And I really tried to kind of simplify and adapt charts and tables to make it more user-friendly for end users like you all, both medical and non-medical. And I think it was kind of successful, hopefully. And I think the other challenge I saw was that HIV is, continuously evolving. It's really fast-paced. There's new medications down the pipeline. The guidelines keep changing. And so I knew what I was writing now would be totally obsolete, in 5 to 6 months from now. And that's what happened, right? It took this endeavor took 3 to 4 years to come to fruition. And during that time, I had to revise this chapter a couple of times. So yeah, so that was a challenge. But I think, what are the other questions? Part of the questions, lessons learned, I get. Thank you, Amy, for all the questions within a question. And so I guess the lessons learned, I think for the process of writing the chapter, I think, it took a lot of time, a lot of effort, and a lot of patience, not just for myself, but for my family and my friends. And also, I learned that you really need to be passionate about what you're writing, because if not, I guess it becomes more of a chore, and the end result, it won't be that satisfying. And I think what the most important lesson I learned from writing this chapter is basically, you can't write a textbook about queer health if you don't talk about HIV, and you can't talk about HIV if you don't talk about the AIDS epidemic and its significant impact that it's had on the history of our queer community. I really wanted to capture or acknowledge the struggles and the sacrifices that our older generation had to go through for us to have the basic human rights that we have today. And, that was a time when a generation of gay men were being decimated by a virus that nobody knew about, and there were no medications. And just to see the struggles, a time of anxiety and fear, and a time of where there was so much blame and shame and religious righteousness, and so much complacency within the medical system and the political and legal system. Just to see how our community, our queer community, and our allies banded together and mobilized the community, did a lot of grassroots activists. And so I really wanted to kind of pay tribute to that. And really the main lesson is that HIV isn't just about, the medical aspect of it, but really also the social, political, legal aspect. And that's what I wanted my readers to learn from this chapter. Yeah.
I think you nailed it, Kwan. You really captured that. I will quote my dad, who read the book and said, the first half of that HIV chapter was truly exceptional. So, and I have to say, I think it's one of my favorite parts of the book as well. maybe we'll loop back to talking about this. I'm curious, when you did the research for that, whether you've come across anyone who's actually done that in the Canadian context before, because I know of a lot of documentaries and accounts of HIV history south of the border and other places, but not in Canada. So maybe we'll loop back to that. But before we get back to that, we're gonna just let Ed speak to these questions. And I'm so curious, because you and I lived through this process together, you know, what you're gonna say about it.
Of course. First of all, thank you everyone for having me here today. I'm so proud to be part of this project. And, you know, in talking about the chapters that I participated in, I feel like I participated in all of them to a certain extent, but wrote chapter 1 and 3 with Amy, the introduction and the prevention and screening part. But the process, I can't describe, I think, each chapter individually, but I think what I feel in reflection is that I'm so lucky to be surrounded by brilliant people, and this project has allowed myself and I think Amy to deepen those relationships with people that, you know, we may have trained with almost 2 decades ago, people that we've worked with for decades, or people who have trained with us. So, you know, I have to say that, you know, this whole experience has been eye-opening in some ways. I can't recall a time that I've had to do kind of a group writing project since high school or maybe university. And so really kind of getting to know our colleagues in a different way as writers and experts, and being really delighted to see how articulate and brilliant they are. So that's kind of what I discovered in the process. You know, speaking specifically to chapter 1, we've already heard this from Nalini, that there has been so much progress, and to kind of list that out and reflect on, you know, the first edition of this book was published in 2003, so almost 20 years ago, and seeing where we've come, but how far we still need to go, I think, is an important consideration for chapter 1, and we put that in there as well. Our chapter on screening and prevention is dear to my heart. I went into primary care or family medicine because screening and prevention made a whole lot of sense to me, just in terms of if you can catch a disease early or prevent it, that really makes, you know, for a better situation for individual patients, their families, community, and the health system at large. And so that really resonated with me. And so instead of, you know, the usual talks that I might give on cancer screening, it was really nice to kind of consolidate everything all into one place. And that's what I kind of look at that chapter as. And in thinking about, you know, these chapters and this whole book in totality, I kind of think of these polarities of, you know, that when we're caring for the 2S LGBTQ community, there's kind of a sameness that, you know, a lot of the things that we might do with anybody, we would do with this community, but there's also unique needs. And I think that's reflected in a lot of our chapters. Another polarity that I've already mentioned is progress, but also balanced off with that we still need advocacy, and we still have a far way to go. And there's probably many more polarities that we need to think about or could describe when we look at this book. The challenges that I found, Jordan's already mentioned, you know, research, we haven't captured those communities in research traditionally. Being in this, in clinical care for about 2 decades, we have progressed, so that's been nice, but we're not doing as nearly good a job as I think we can. One of the last things I think that maybe not surprised me, but I've been delighted about is I actually use the book in my clinical practice. Even when we were writing it, I would go to draft chapters and look up things, and I have it on my desk at my office, and I use it to look up, you know, treatments, look up information about HIV, you know, dosing of hormones and things like that. So it is a useful chapter or book. So I'm really glad about that. I'll leave it at that.
Thanks so much, Ed. I think one of the other polarities that comes to mind for me that we tried to balance was sort of, on the one hand, you have this process of outlining the disparities, of outlining historical oppression and wrongs. And then on the other hand, you have the resilience of our communities and the change that we have enabled. And so that just came to mind when you were listing out those polarities, because we certainly didn't want to you know, dwell solely on the things that are challenging and difficult, nor did we want to pretend that everything is Perfect. So I think we're about right on time to move on to our next question. And I think some of you have touched on this a little bit in answering the first question. So, I mean, Ed and I are really proud to have the vast majority of contributors to the text be speaking from a place of lived experience as members of the 2S LGBTQ community. And I wanted to ask our panelists, in your opinion, where does the value lie in primarily having contributors who are 2S LGBTQ identified as chapter authors for the text? And I think I'm going to pick on Jordan.
Yeah. So yeah, I think overall, the teaching that we do have in sexual health tends to be very heteronormative in terms of the practices that we may assume that patients are engaging in terms of screening, testing, diagnosing STIs and treating STIs. Yeah, I think that, you know, I obviously have come into it with a different lens from the get-go. So while a lot of the teaching is very maybe heteronormative in nature, you know, coming from the community, you know, having friends who have had diverse sexual experiences and sexual practices has actually lended itself quite well to at least having an idea of these on my mind, right? As I'm researching, as I'm writing the chapter, sometimes people don't know what they don't know. And so that's what I really wanted to identify is, you know, what will providers maybe not know to ask about? What sort of things maybe won't come to mind, especially if the topic as sensitive as sexual health and sexual practices. Patients won't necessarily volunteer that information, and I don't necessarily expect them to, right? It can be uncomfortable to talk to their own friends about, let alone a provider who, you know, they hopefully have developed a relationship with, but maybe still won't feel extremely comfortable about. So I felt like just coming in with that lens alone, and, you know, that helped me to identify what providers wouldn't necessarily know about or ask about, what differences and discrepancies arise, and so what to really highlight in the chapter. There are some things that I think are good to know for every provider and, you know, for every patient, right? In terms of, I did outline and put some summary tables in terms of the various STIs, their diagnosis, their treatment, window periods, things that even for, you know, assumed cis hetero patients, a lot of the time providers struggle with. I did include some of that information, but really I wanted to also highlight the differences that exist, right? So screening extragenital sites, in other words, doing throat swabs and rectal swabs as appropriate for gonorrhea and chlamydia, right? Hepatitis C testing and understanding what practices may put an individual at risk for hepatitis C transmission through sex. Kind of knowing what is already taught and maybe what practices maybe are engaged in the community. Another one, party and play, right? The use of drugs to facilitate sexual experiences or to heighten them. That comes along with its own benefits, its own rewards, but also its own risks and potential concerns. And so, you know, really just being privy to what's going on in the community has helped me to shape and organize the chapter in that way.
Thanks so much, Jordan. I totally can relate to a lot of what you're saying. And I'm sure we all can. Sydney, why don't you chime in and share with us your thoughts on this topic?
Sorry, Amy. I was so enthralled in Jordan's answer, I've forgotten the question.
Yeah, so we're just talking about, you know, where does the value lie in, you know, having people who are part of 2S LGBTQ communities be contributors to this text?
It really, you know, so sorry, I knew this would come up. I've been alive for a long time. I was born in the 60s, was a youth in the 70s and 80s, went to medical school in the 80s, and have been practicing medicine since 90-ish. So I've seen a lot of change happen, and my lived experience has changed significantly. My personal evolution has changed significantly. And over time, you realize I have looked at this world through a white, cis, hetero, male lens that is both colonial and white supremacist. And as we move through these things, what Jordan was describing and what Kwan was talking about earlier on with his chapter too, is I've watched the evolution of HIV, because HIV wasn't known when I was born, didn't exist as an entity. It was this new thing that happened when I was in high school and exploring my own sexual and gender identity, and then realizing, oh my God, we're all just gonna die. And then, crawling into a closet because you didn't want to get this horrible disease. And so being queer, being gay was just like completely enveloped in pathology. Not only was, I remember when it was illegal to be gay, but the DSM, for example, had homosexuality in it until I was in medical school as a pathology. So these things are, it could be a very long answer here, but I want to keep it kind of short. But my lived experience, of course, has been really broad and changing over the years. And when I was in medical school, if a gay man walked in, or someone we assumed was gay walked into the emergency department, everyone would completely gown and glove, put on a face shield, which we're familiar with now in the pandemic, just because the person seemed gay. So, a lot has changed, as Ed was saying, but we can't rest on our laurels because so much of what we do is grounded in colonialism, white supremacy, various forms of oppression, and significantly the lens of a white, cis, heteronormative physician's viewpoint. All our textbooks are written from that viewpoint in general. And so for us to be contributing to something that, with our lived experience, I don't know if you can see it, we're contributing and we are the ones who are doing this. That's pretty new. That's pretty new. There's not too many, population-based medical texts out there that are written by people with lived experience within the population it's meaning to serve. I'm not aware of any, other than all the textbooks are meant to serve cis, heteronormative men.
So true, Sydney, so true.
And I make no apologies for my language there. History is history.
Yeah, I like that you make the point of also of the diversity of our lived experiences and the commonality. Like sort of we've all gone through some sort of health care professions training in a very colonial system. And we are all different ages. We all have very diverse lived experiences. And I think one thing in your chapter that I really like that you pointed out, Sydney, is that, just by virtue of being queer identified doesn't make you a culturally competent provider in all the ways that you need to be. And in many ways, it's the work that we've done on the ground with our clients face to face over the years that has informed our writing even more than our own identities. Zhangwei, you eloquently spoke.
It's an N of one.
Sorry, Sydney, go ahead.
It's an N of one. So I just wanted to add that, like, your lived experience is only part of it, and the more you rely on your own personal lived experience, the more assumptions you can make and hurt people. So we never do that, right? We never do that. This is collective experience, and I wanted to address that because I think that piece of like, well, you're one of those, so you should know. I mean, that's just like a horrible way of assuming things about a person.
Yeah. I want to turn to Zhangwei now. You spoke eloquently to sort of how your own lived experience almost, happened in the process of this chapter, or at least your own awareness to an extent. And thank you so much for sharing that. What are your thoughts about this conversation that we're having?
Yeah, thank you so much. I've really been taking in everyone's what they've been saying and what they've been sharing. And I think this is what the importance is of this book and these chapters being written by, people who have lived experience, who are, working in the field, but also, walking out everywhere every day, facing these like microaggressions, but also like overt, prejudice. And so for me, going back to it, I know as a child, I didn't see much good representation of Indigenous peoples anywhere. And growing up in the downtown East Side area, there was a lot of HIV and stuff like that. And so for me, this chapter was also, again, a reflection on, myself. And growing up in school, I was Two-Spirit, since I was born, but, and people would tease me, we can't tell if you're a boy or a girl, and like all this kind of stuff, right? So learning about, what feels safe, what is it safe to be, right? And so working through this chapter, it's like I reawakened myself, because I was like, going through this, all of the research, and there's not much of it, right? And but then sharing space with these co-authors and going, wait a minute, I'm safe to say this now, and writing it even in the chapter was like, oh man, what does this mean, right? And so for myself, this is sort of like a microcosm for anyone, right? Where maybe they read one of the chapters or any of the chapters and they're like, wow, actually, you know what? I think I am lesbian, or I feel comfortable to say that I am a lesbian, or whatever that looks like, right? And so for me, I remember when I was like, I'm going to acknowledge that, and being able to say that, I think, is really important. So what comes to me is really thinking about the labels that we have and the labels we give to patients. And Sydney was talking about how people are diagnosed, under this lens, right? And being illegal to be queer and all of this kind of stuff. And although those things have changed, we see that there's still a long way to go. And for me, I just feel so privileged to be a part of the chapter and to be able to actually share my voice, because there's not a lot of, we've been talking about, not a lot of literature out there or publications, but, would be considered in the Western ways of knowing and being that is acceptable, let's say, right? And so that just goes back to that colonial violence and really that oppressive structure that we all are working in. And so having these stories written by people with lived experience, again, may open up opportunities for other people to go, wow, okay, these people are doing this amazing work, and what can we build off of? So yeah, there's just so much, and so much vast knowledge in one space. So thank you.
Thanks so much. Juan, you alluded to sort of learning that you needed to be passionate about the work or about the writing. Does that, relate to, your lived experience, or is that separate? And how do you feel about the conversation that we're having now?
I think the HIV topic itself is a very important topic for me, both personally and professionally. It affects me every day in my life. And it also affects a lot of our patients in our community. So, so I think through lived experience, it builds connection. And, I remember in the 1980s, I used to watch Tom Brokaw on the news. And for those who don't know who Tom Brokaw was, he's this really handsome US news anchorman on NBC. And I remember in the 80s when I would watch the news with my family, and I could see, people talking about this new virus that was coming out infecting gay men. I could see AIDS patients in hospitals being interviewed. I could see protesters on the streets wanting AZT, and people burning effigies on the streets. And I saw that and I watched that in the 1980s. And, I was intrigued, but I didn't have a connection to it. And then I think while I was writing this chapter, these images from the past somehow kind of started to emerge from my subconscious somehow. And I started to really identify and connect with what I was writing about and to connect with my community more. And really, I wanted my readers to be able to connect the same way that I did. And I think that's what medicine is all about, is about connection, right? Whether you identify as 2S LGBTQ or not, especially our audience members who don't. I think medicine is about connection. Our patients are looking for connection, whether it's with their past, with themselves, or with the healthcare provider. If we're able to kind of, reciprocate that connection, we could build a stronger therapeutic alliance and move forward with our patients, right? So thank you, Tom Brokaw, for helping me make this connection with my community and with my chapter and helping me bring this into words. Thank you.
I'm getting so enthralled in people's responses. I'm forgetting to keep track of the time or any of the things I'm supposed to be doing. Ed, I think we haven't come to you. And maybe it's good we're coming to your last as an editor, where you were sort of able to see the book as a whole from the early stages. I'm interested, what to hear from you on this and your opinion about the book as a whole too, in terms of the meaning of having lived experience.
Yeah, and reflecting on this, I have two thoughts, and I certainly agree with all of our co-authors as well. And just thinking about this, thinking about the passion that our co-authors had, as well as yourself and me, Amy, I think we want to get this right as members of the community. I think that there's this interest in making sure that this book or our chapters are a success, that we're clear, that we give good information to people. I don't know if we would have that if we were writing on a different topic. I was thinking outside for myself, if I was writing on Gregorian chants or art history, things that, I'm not part of that community in any way. My apologies to our musicians and artists or art historians. But I think that there really is that desire for us to get this right. And I think that having had that experience of stigma or other people getting it wrong, or even getting it wrong ourselves, is a strong motivator for us to write a great textbook. And certainly having that lived experience makes a lot of sense. From an overall perspective, just hearing our co-authors today and thinking about the previous version in which there were two authors or editors, we now have multiple luminaries or leaders in the 2S LGBTQ community who've been part of this textbook that learners can go to and get more information and knowledge. So I think we've actually expanded that reach of people with lived experience, varied experience, and that diversity in a much more meaningful way than had been done before. So if that's kind of my impression of the general impact of lived experience in the textbook, I hope that is true.
I think you summed that up very nicely, and I don't even think I need to wrap that conversation up into a bow, because I think that you've done that. I think we could chat about this more. It'll probably be woven into the future conversation in the event. But let's move on to the third question that we have as the curated part of our discussion today. And this is where we really wanted to take a look at the future. So, in the process of writing the chapters, we all did a lot of research about the past, what is known, but we, also were able to really identify some of the gaps in care. And I'm really curious to hear, now that, writing the chapter even is in the rearview mirror by a ways. What are your thoughts now on, what might be key steps in the area of your chapter in moving forward to actually improve health outcomes and address barriers for patients in Ontario and Canada more broadly? Kwan, can I ask you to start with that one in regards to HIV?
Sure, Amy. So key barriers, I think one key barrier that I can think of is basically revamping the way HIV demographics is documented for HIV surveillance in Canada. At the moment in Canada, I don't think there's any federal mandate or standard protocol of how we gather data and demographics for patients who are newly diagnosed. So, the provinces and territories kind of voluntarily pick and choose what they submit to the Public Health Agency of Canada. So, you have provinces that might report like race and ethnicity only. And then you have Saskatchewan here who reports, Indigenous versus non-Indigenous. And, if you look through some of the reporting, a lot of times trans and non-binary gender diverse populations aren't even captured in that. And I think, by revamping the way we do it, we're able to kind of disaggregate and look at, ways to better target funding and target where our prevention efforts and treatment efforts go to. So I think that's one of the things I would say is a barrier. A second thing I would say would be not to forget about our older HIV patients. I think, especially with the advent of newer medications and the advent of PrEP and PEP. So for those who don't know, pre-exposure prophylaxis and post-exposure prophylaxis for the prevention of HIV. I think with the advent of that, I think there's been a kind of like a disconnect between what it is to live with HIV in the past to what it is to live with HIV now. And so we seldom acknowledge our older generation folks, and oftentimes we forget about them. And I feel like we need to, I feel like today's generation, we're kind of unaware of those struggles and sacrifices from the past that they've done to give us the basic human rights that we have today that we sometimes, take for granted. So I feel like, a lot of our older HIV patients, they're going through a time where they're starting to question their own mortality. And then there's a bit of survivor's guilt. And, I can't imagine the unfathomable loss that they endure, seeing their families and friends die of AIDS. And so just to kind of neglect them that way is just a tragedy to me. And so I still see that there's this intersection between ageism and HIV stigma that still exists in the community. And I think that's really sad. So I think a key message here is that, we don't forget about our older S2 LGBTQ patients, whether they're HIV positive or not. I think because they come from an era where, they fought for our basic rights and we need to kind of embrace that. And I feel like it's been lost a bit through the generations. And I think lastly, I think another key barrier is that HIV stigma still exists. I know we live in Toronto, we live in an urban city, and I feel like it's still there, internalized, externalized within the community or the general population widespread there. Personally, with all this new medications that are coming out, with all the new PEP and PrEP, all this talk, I personally I'm kind of scared that we're reaching a point where we begin to kind of forget or even trivialize what a new HIV diagnosis means to our patients because of the new medication and because they're so simple to take. And so when someone is newly diagnosed with HIV, I think it's not just here, take your medications. you're fine. It's a manageable disease. It's much more than that. And that's what I'm scared of. And so, for some of our clients, it might be coming out gay, coming out as trans, and then coming out as, HIV positive. There's this whole loss of networks of friends and family. So there's so much more than that. And that stigma really does still exist. And so what I want my readers and want people to realize is that, please don't trivialize or downplay a new HIV diagnosis at this moment in time, because, a patient's experience with HIV is so different and so deep. And again, that's how we build the connection. So.
Yeah, it really sounds like on one hand, there's been a rapid evolution of the medications and the science around HIV, and it's all moving forward, but we're really almost forgetting about the personal aspect of things, particularly for, people who are of older generations. I want to kind of encourage us to be in a bit more of a conversation about this. Is there any of the other panelists that want to take off where Kwan left off and talk, either adding on to his comments or speaking a bit about what they see as key aspects that need to be addressed in moving forward?
I think maybe Zhongwei, do you want to go, or me? Just to add to Kwan's comments, I think not forgetting about people who have been mistreated or frankly abused, and the impact of that, whether it is through reconciliation, or in chapter 1, we do talk about the federal government making reparations for their misdeeds against gay and lesbian people many decades ago. And I think that's an important point not to forget, and to keep that work moving forward, and hold our government accountable for some of that work in other organizations too. So that really resonated with me, thinking about people, we have, again, we've made lots of progress, but not to forget those people who may have suffered as a result of that, or advanced it and suffered as a result of it.
Zhongwei, did you want to add something as well?
Yeah, thank you. There's been so much that we've all been talking about that I think, again, there's a thread that runs through everything, and it's really reclaiming identity, right? And it's sort of the importance of having this book. But I think too, a few important things that I've been reflecting on as we've been speaking is that, how similar a lot of our experiences are, and it's been brought up a couple of times, but not to dismiss the uniqueness that we all have. And even though, my chapter focuses on, Indigenous ways of knowing and being, a lot of that, can resonate with other people who have been marginalized and who have faced certain things like that, right? And when we're talking about, again, that intersectionality, it's like, it's seeing that holistic part of the person. And I think this is a good way to show that, like, where we are looking at, different aspects of gender specific care, but we're also making sure that it's not just like a one, this chapter is like by itself, right? It's like, so I think if we're talking about HIV in Thunder Bay, we have a large population of people who are Indigenous who have HIV and who don't identify as queer. And so, that chapter is really important to me to be looking at too, and figuring out different ways to explain things to people who might have questions. But, we're talking this being a second edition, right? And people might not be aware of how long it takes to actually put a book together and to, get it published and all of stuff. So we kind of mentioned it a few times that, right now we've brought it together so much new information, but information is changing so rapidly. But there's so many things in these chapters that are going to stand the test of time, that are going to actually open people's eyes and go like, oh, wow, like, and changing the way clinical practice is done, but also just how we treat each other in our day-to-day lives, and I'm thinking back to like my practice as a nurse practitioner and meeting with patients. And when I first started, it was like grade A guidelines. I'm like, you got to do this. It's not to say I didn't do that after, but I realized that those guidelines were tested mostly on, cis hetero white people, right? So, does that actually really fit the population? So I think in these chapters, it gives us an opportunity to kind of look beyond black and white and go, like, there's no evidence because it hasn't been studied, right? And it's sort of opening that door, paving the way. So it's a stepping stone, I would say. So, there's so much more we can look at. But I think, again, we're starting in this, like, the spot of the history. Where do we come from? Where are we now? And where are we going? And I think there's so many amazing things coming. And, but I really liked, how Kwan said, like, not downplaying, whatever that is for them, and if it's an HIV diagnosis, because it is scary, but also knowing, like, people are carrying that around. And I really appreciated how you talked about sort of a layering of revealing the layers. I feel that, right? Where it's like, what's safe? Okay, maybe it's safe now to say that, like, I'm queer, and now it's safe to say that I, have HIV. Like, what does that look like, right? And the more we can give people the tools and, like, maybe even the words to say it, or how can they even, have that conversation with their healthcare provider or their social worker or whoever is providing care for them. And for people who are service providers, we're often told, treat people how you want to be treated, but we need to treat people how they want to be treated. And so it's really asking people what's the best for them. But one last thing I just wanted to mention when I was thinking about, prescribing birth control to female patients, or, assumed female patients. And when I was working alongside another healthcare provider, they were very adamant. They were like, well, you need to go on birth control. Don't you know you're going to get pregnant? And she was like, had to out herself, right? And she didn't feel safe doing that. And she's like, well, I'm a lesbian and I'm not worried about having a baby, right? But because we have these judgments, and there's such a power differential between healthcare providers because we have the knowledge and whatever, but we need to remember those people, everyone is, they know their own bodies, and we need to be non-judgmental and offer that space so they feel safe. So yeah, thank you.
Jordan, I was hoping you would offer to add your thoughts.
Yeah, no, absolutely. Yeah, I thought a lot of great points overall were brought up. And I think one of them that I'm glad is gaining a bit more attention these days is the concept and how to help patients who are or clients who are aging with HIV. And so that's something that Kwan was touching on. These days, with the exception, rare exceptions, HIV is not a death sentence, right? People can live very long, very healthy lives with HIV. But we have to also recognize kind of what risks may come along with having an HIV diagnosis. And I think this is an area that hopefully will continue to get a lot of attention and we'll learn more and more about, because there's populations that have been on older regimens that, as discussed in Kwan's chapter, have more toxicities, have more risks in the long term of things like heart attack and stroke and diabetes and weight gain and different cardiovascular risks. But there are also newer regimens out there that may have fewer risks or different risks altogether. And so I think hopefully over time we'll be better at individualizing our care to patients based on their unique experiences. But one other thing that I wanted to mention too about in general aging with HIV, but also how we view HIV, recognizing there is still a stigma there. But also I think one of the things that we've tried to emphasize is how we can help to smash that stigma, right? Recognizing that individuals who are on treatment, who have been able to reach an undetectable viral load, cannot pass HIV through sexual contact. And that's still something that actually a fair number of healthcare providers don't know or don't emphasize to patients, and that some healthcare providers maybe assume that patients already know. But even with this principle of U equals U, there are still, and probably particularly older individuals living with HIV who still have that trauma, that they went through with an early diagnosis, with seeing so many people around them pass away with HIV. They're concerned about transmitting to others that, and this is kind of tying it into my chapter about sexual health, but they may choose to avoid sexual activity altogether. It may affect their sexual kind of pleasure or sexual satisfaction. And so one plug or one thing that I'll try to emphasize that people do is exploring that with your clients, right? Meeting them where they're at, but recognizing that there is that stigma that affects a lot of components of their health, sexual health being just one of them.
Yeah, absolutely. I feel like there's some themes coming up, and one is that there is a lack of data, a lack of research, a lack of a concerted and organized effort to gather information on our population and our health. And the other is around oppression and the history of oppression, the experiences of oppression, and the health impacts of discrimination. And it seems perfect that we're moving right to Sydney, given your topic of the chapter and your areas of expertise. Sydney, I'm so curious, to hear what your thoughts are on the conversation that we're having, and where you see the best, like, what are the low-hanging fruit? What do we need to do next to make things better?
I don't want to address the low-hanging fruit, actually. That was a very good segue into, but it is very creative. But I don't want to address low-hanging fruit. I don't think there are any. I think we're at the stage of, I think things like, let's be politically correct. Let's have legislation. Let's have policy. That's low-hanging fruit, right? Anyone can tick off boxes. People can tick off boxes. We can have a form that people fill out, which is what I recommended in my chapter. The issue is the barriers are always systemic. And when we use the word oppression, people feel that, that's a deliberate thing, that I'm oppressing someone, right? I just decided to go to a party today and oppress people, right? Because I just, and that's not what it is. Oppression is a systemic thing, right? We practice it. All of us practice it. Everyone in the entire group, all the attendees, if they work in healthcare or social work or psychotherapy, we practice systemic oppression every day because of the system that we are. I'm a racist. I'm a homophobe. I'm transphobic. I'm a sexist. These are things that I practice every day because of the system. And so, we have to understand, like, we have to be trauma informed in this, that we have a lot of privilege here. And we have to use that in a way that can make sense to a client who's being told, you have now been diagnosed with a chronic disease that if you didn't take this one pill every day, which has been the dream of HIV, patients for decades, one pill a day, once a day, what more are you asking for? Like, you're not going to die if you take this pill. But if you don't take this pill, you're going to die. It won't take long, 5-10 years maybe. And this pill is going to cost you. You might have coverage for it, sure, fine. But ultimately, it's going to cost someone something. They're very expensive, these drugs. And so I was one of those doctors that, 10 years ago, when we started getting better and better HIV treatments, told people, I tried to normalize things, right? That was part of my anti-oppression approach at the time is, well, being gay is normal, being trans is normal. Having HIV is normal. It's no worse than having diabetes. Your life expectancy is about the same as someone with diabetes. Well, what about the diabetics? That's a freaking trauma, being diagnosed with a diabetic. So when I realized that I was doing this and this was happening and I had the power to prescribe these medications to save people's lives, I really started to realize all the diagnoses I make that are pathologies, that are diseases, that are a change in a person's health, they're all traumatic to patients, to my clients. And when I have a diagnosis, it's traumatic to me. And sharing that vulnerability and sharing that and realizing, I am so sorry that you have this. And yes, you don't have to die. You know, that's the silver lining in this horrible part of your life story that's suddenly being landed on your lap. So that's the trauma-informed piece of it can't be understated, I think. And that every patient, every client that we take care of that is landed with a diagnosis or a label or whatever you want to call it, or suddenly has to change their life because of something that they've done or not done that wasn't their fault. And you know, the intermeshing, the interweaving of HIV, for example, and sexual activity and sexual health and sex is rife with all kinds of stigma that's systemic, that's been going on for religious, medical for sure, moral. All these things are interwoven there. And to take the diabetes parallel, yeah, diabetes is rife with fat phobia, weightism, sizeism, those kinds of things. So there's so many parallels that I think there's no diagnosis you can have that's not traumatic to you. And these are every HIV, every person I've ever diagnosed with HIV has, to quote all of them, has said to me at some point, I've ruined my health. Sometimes with one bad choice. They're still saying that. So despite science, there is still the system that causes people to think a certain way, and it's still heteronormative and it's still cisnormative. So I never forget that, right? It's one of those things that like colors every day of my life and everything I do.
I think it's so interesting that you know, nobody's answer, despite the various topics that you've written on and that you are experts in, nobody's said, you know, we need to move the medications forward. We need, you know, I mean, we say we need better data, but everybody's number one theme is like, we need to, it comes back to humanity, that piece that is missing in how we are trained to do the work that we do, and the system structure that places constraints on how we do the work that we do.
Anyone, Amy, I just want to add to that. Anyone who's ever had a serious illness that's been cured, you know, even when we have a cure for HIV, when we have a cure for various things, even when we treat trans people with the ultimate treatment and they get everything that they need to control their gender identity or gender dysphoria, for example, you know, there's so many things that we cure. I had pneumonia once a few years ago and I got antibiotics. The pneumonia was gone within a week. It's affected my body for the rest of my life, right? A cure does not mean there's no trauma. Even. So I think that the piece is, yes, we're talking about a lot of social things. Your point is that, you know, no one's saying we need more drugs. We need a cure for sure. But you're right. I mean, it's the experience of, you know, health changes that really is a very human piece of it.
Mm-hmm.
You know, like we could go on and on about systemic stuff.
Yeah,
all day long,
we could,
you know,
and
so.
I believe we have some questions from the participants that are have been listening to our conversation, and I'd like to get them involved as much as we can in terms of finding out the you know, high level or theme questions that might be coming in for our panelists. Allison, are you able to jump in?
Hi, yes, I am. Thanks, Amy. You know, one of the themes that I'm seeing emerge in the questions is around 2S LGBTQ refugees and newcomers. So especially around access to family doctors, as well as general lack of care for newcomers, if anybody wants to address that.
Yeah, I mean, unfortunately, we couldn't have all our chapter authors on the panel today because it would be unwieldy, but there's an entire chapter on LGBTQ, 2S LGBTQ refugees and newcomers that addresses a lot of the challenges that they face, in addition to some of the systemic issues with IFH. Ed, I don't know if you wanted to add to that, having been part of working together on that chapter with the author.
Yeah, I think that it does answer a lot of questions on immigrant and refugee members of the 2S LGBTQ community. And certainly, yes, it's unfortunate we couldn't have all of our chapter authors here, but maybe that speaks to RHO maybe needs to have another one of these sessions with the other chapter authors, so everyone gets, you know, a good voice to participate. But again, it's a very solidly written chapter by our colleagues in Ottawa. So have a look at it, and I think it'll answer some of those questions.
Any other questions that have come through, Allison?
Yeah, I think this is especially a great question for the editors, but there might be other people who have something to say. There was also a question about the title of the book and not using Two-Spirit or 2S at the beginning of the acronym, and whether this might be a change for the future.
Yes. So I'll speak a little bit to that, and then Ed, if I've missed anything, you can add. So basically, when we started this process and engaged in the process to sign the contract with the publisher for the book, I think we were back in 2015. I was pregnant. I have a 6-year-old now, so it was quite some time ago. And the acronym that was in common practice at the time was LGBTQ, and then LGBTQ2S was also starting to come into play. And so when we signed the contract, the title was as it is on the cover now. Throughout the process and the years of working on this, as this was coming together, so much changed. And the practice of putting 2S first emerged, and Ed and I really wanted to honor that. And we unfortunately faced some barriers in doing so on the title of the book. I think that from the perspective of the publisher, there was a concern with the marketability of the book, as the acronym wouldn't be as easily recognized outside of the Canadian context. And Ed and I got on the phone with the publisher and we pleaded our case. And at the end of the day, they declared, you know, that they had the power to make that decision because we had signed the contract. And we were really upset. And I absolutely hope that in the next edition, nobody signs a contract with the acronym this way. And Ed and I, even though we had signed a contract about the cover, we were under no contractual obligation in terms of the content of the text. So you will see that the only place that the acronym doesn't have 2S first is the cover.
Yes, very sad that we weren't able to make that change, as Amy said. And we vigorously argued with the publisher on several occasions too. And I think one of the other elements that Amy didn't mention as well is that the text is not our own, but also intellectual property of the previous editors who were on side with the publisher as well on that argument. Again, we really do recognize that we wanted 2S first, and we're glad at least that we have it everywhere else hundreds of times, maybe thousands.
Thanks, Ed. I don't know if anybody wants to add to that. I know, Sydney, you were, you know, had a lot of passion to support our cause when we were trying to have the title changed. I also don't know, Allison, if we have other questions. I can see that we are coming up to 3:30. So sort of in about the last 10 minutes of the Q&A section here. So I don't know, Sydney, if you want to just add a quick word on that, given the topic of your chapter, or whether you feel like it's been said and we should move on to further questions. I'm open to either.
Yeah, I can say a quick thing. I mean, I think, you know, this is just a reflection of how deep the unbridled systemic oppression is. In this case, it's unbridled capitalism. It's uncontrolled in a lot of ways. It's purely around the marketability of a book, and specifically around how it would look on Amazon in the US, as if there are no two-spirit people in the US. And so I think that is very unfortunate. Now, at the time when I heard about this, I was furious.
Yeah, we all were. Allison, do you have any other questions from our participants?
I see one other theme emerging in the questions. Thanks to everybody for submitting. There's a few questions around universities and colleges providing curriculum for gender affirming care specifically. We know that this is medically necessary health care.
So I think the question is sort of around why the hesitation or why the limitations, why hasn't this been incorporated in a more robust and standardized way, knowing what we know about how that these treatments are medically necessary. Yeah, go ahead, Ed.
Yeah, I certainly agree with the comment. However, my kind of ecosystem of education is based out of the University of Toronto at the moment, for which they have done, I think, a great job there. And as you heard in the intros, that Amy was the inaugural 2S LGBTQIA+ lead for the faculty, as was I. And there is a good amount of representation in the curriculum in the undergraduate program that is interwoven as part of what our new medical students learn. I think that they're kind of the exception, and I haven't seen it done as well elsewhere, and maybe the other panelists have, so I'll let them speak. But so I think that there is great work being done. It's just not being done everywhere. I think that it is slow to move, and I alluded to practicing over about 2 decades now. And so just, an example in my practice, some of the physicians who are newer to practice are more likely to care for people who need cross-sex hormones than referring them to an endocrinologist. And to me, that is a bit of a success, that we're building capacity within regular general practice or primary care, which is where a lot of us work, for people to care for our communities. But is that being done at every medical school or nursing school or social work school? I don't know it. And I think that there probably is not as great an effort elsewhere or everywhere.
Jordan.
Yeah, I can comment on this too. Also from a perspective of being a faculty member with the University of Toronto's MD program. One of the exciting things is that our new associate dean has really prioritized gender affirming healthcare, and kind of looking at the current curriculum, ensuring that we update it, but also revamping the way it's taught, kind of creating more resources that are appropriate for learners earlier in their career, because there are some phenomenal resources out there for practicing healthcare providers, for instance, like the Sherborne Health Guidelines and whatnot. But I think that is a very exciting project that I will likely be involved with alongside of our associate dean and some other providers, and trying to create. And the goal ultimately that's coming out of the project as well is that the resources would be shared more widely, so that they actually would be able to be used, by other medical schools, but also other healthcare professions, social workers, psychotherapists, RNs, etc., which is kind of exciting and unique, because I feel like different healthcare profession programs and even different medical schools, right? Even though there are a certain number of topics and things that need to be covered, they don't often communicate between one another and don't often share resources. So there are some exciting things that have been put into place by our phenomenal previous 2S LGBTQ theme leads, but also that, I think will be an ongoing project, which is exciting. And I also do want to talk a little bit about, being at the Rainbow Health Ontario's webinar today. Rainbow Health Ontario does offer different training programs and resources to various care providers, right, of different professions. So basically we recognize that there is this gap, and that we can't, of course, force anyone to take any of these training programs, but to make them available, to make them accessible in rural communities. Because I think one of the questions was also talking about, increasing capacity in primary care in general, but also in rural communities where maybe it may be difficult for patients to find individuals with this expertise or with comfort in providing this care.
Yeah, I always reflect on education as being a key piece of how to move things forward and make things better for the health of our community. Looping back to what we were talking about, what Sydney was talking about, how in health professions training, you almost have your humanity trained out of you. That this is the opposite of what we should be doing to train the future workforce to meet the needs of our patients of all kinds. And I think it goes broader than that. You can talk about admissions. Are we looking for the right people? What qualities are we looking for in the people that we're recruiting to our future healthcare workforce, whether they be physicians, nurses, social workers? What is the diversity in that? How can we encourage that diversity as an asset in that admissions process? And so I know that there is work like that that's being done in bits and pieces all over the country. A lot of times this work is spearheaded by learners, the next generation, which is awesome, but shouldn't have to be that way. It should be coming from the top. I think, in terms of answering the question of how do we move forward, I think education in healthcare professions has to be a really big piece of that. And I think that's been the case for 10 years and we've made some progress, but it still needs to be, an ongoing effort in that regard. So Allison, I think we have another question that you had from the participants.
Yes, so I want to say there's so many excellent questions in here that it's really challenging to sort of choose where to go next, but one thing I think is good to touch on is around cancer screening. So the question is, a few of the panelists spoke about considerations for cancer screening in the 2S LGBTQ community. What messages would you want to provide? Sorry, what messages would they want to send to the wider primary care community about how to effectively provide this care to the community in this area?
We're working on it. Cancer Care Ontario is working on it. We have more robust evidence around the benefits of screening for sure. But I really think that cancer screening should be based on the body parts you have and not by how you're identified at birth or what it says on your ID. So if you have breasts, you need a mammogram at the right age or based on risk factors. If you have a colon, you need a colonoscopy or a FIT test, right? Like that's kind of universal. If you have a cervix, you need cervical cancer screening. So regardless of what it says on your health card, and currently the health system is like, well, if it says M on your health card, then you don't get a reminder for your PAP. And we're working on it, right? Like RHO does not, Cancer Care Ontario, RHO as well. They don't have an unlimited budget or resources to lobby the system. And there's always one part of the system and another part of the system. It's not a simple relationship. So I think we are working on it. Ed has a much better answer than I would.
No, it's probably the same answer. So I agree with you when, we sometimes do a whole hour-long talk on cancer screening, but certainly remembering what organ systems are there and offering that appropriately. A lot of it, that's very simplistic, but it's the communication and how you approach that topic, I think, is probably the most important with our patients. And in cancer care in general, they talk about individualized medicine. When people do have cancer, matching a specific receptor to a specific treatment. I kind of think about individualized medicine as even that discussion about cancer screening or any care that we do, that we really have to meet that person, that unique individual before us, to ask them what language they use in describing their body parts. Have they had screening before? What was that like for them? So I think of that at the sort of micro level, but we also have to think about this as a systems level issue, as Sydney pointed out, that the system isn't built to offer organized screening to everybody, depending on what one's health card has as an M or an F. And so as Sydney mentioned already, that Ontario Health and Cancer Care Ontario are committed to working on that. And as well, educating people on who needs screening, which I think has been a gap as well for a lot of primary care providers. So again, lots of work to be done there, but it is thankfully moving forward, a little bit slow though.
Ed, can I ask a question?
Sure.
I think I'm a dumb little family doctor, so I don't really understand the big language. But what I'm hearing from you is listen to your patients, listen to your clients, right? Be trauma informed too, in terms of like asking them what they want to say, but listen to them and treat them as individuals versus doing what your EHR tells you to do or what a system tells you to do. You still have to like filter out the fact that these are individuals who may not fit into a certain mold, as in all healthcare.
That sounds like the advice of a brilliant, well-seasoned doctor.
Sangwe.
Yeah, thank you. I wanted to add something here too, and talking. I also worked alongside with Ed at Cancer Care Ontario, and talking about again the intersectionality, but also meeting the patients where they're at. Like we've talked about that a few times, and going by the prescribed like guidelines. Like again, those guidelines fit like a majority of the population that was tested, but we have to again make space for people who maybe don't fit the guidelines, right? And I think we talked about education and how important that is, and how like we need to, coming from the top, but also coming from the bottom, and we kind of meet together, right? Because we want to make sure that people who are accessing healthcare are getting safe access and being able to get the care anywhere they are. We talk about that's supposed to be what health care is in Canada, right? Is to get access anywhere, but we don't see that. So having like a book like this is again, it's a continuation, so we can say, okay, now we see some of the issues that are happening, and it's on paper, right? Like that's what funders want. That's how we mold policies to work the ways that need to work for patients instead of the other way around. So I think in that way, like, having a textbook like this is something that can be used for teaching, nursing students and medical students for sure, and social work students, anyone really. And, I previously was a lecturer for the nursing program, and like we were scrounging to find books like this, and so again, I just think it's a really good testament to the work that everyone's been doing together. And like we talked a bit about how we work in silos, but it really, shows the importance of us coming together and providing holistic care, and providing care that, is really providing not just one simple thing for that patient, right? And we might want to talk about cancer screening with them, but they don't want to talk about that, right? Because someone in the community might have just died by suicide, right? Whatever that is, it could be the Indigenous community, the queer community, doesn't matter. So again, it's like, what Cindy was saying is meeting patients where they are and what they need. So yeah, thank you so much for this conversation. It's been wonderful.
Zee, did you want to add something to that? I think your hand was up.
I think jumping off from the thing of guidelines, and I did see a couple of questions in the Q&A that were along this theme, is the idea of mandating care, because it is the standard of care, it's beneficial to patients. And so there should be a mandate. There should be, sorry folks, but there should be legislation to legislate specifically doctors and nurse practitioners to prescribe trans care, to prescribe HIV care. And that's one way of looking at it, I suppose. But we know the idea of mandates, once they're there, they don't go away. And the standard of medical science changes constantly. So what's right today may not be right in 10 years or 5 years or 5 months. So these things can be very dangerous. And as Zhongwei was saying, there are guidelines, right? And all these things that are published in the book, they're guidelines. And my teaching to my students and my peers is we don't practice guidelines, we practice medicine, which means it's granular to the individual level. And so to mandate that every doctor and every nurse practitioner has to do something they're potentially uncomfortable doing and haven't been trained to do, and mandating that every student has to learn something that really is evolving at this point. HIV care also isn't a core thing in medical schools, right? It's a core thing for specialists, or people have developed an interest in a specialty and then can have further training. So I think that that's the way that it keeps us honest and oriented towards individual clientele and people. Whereas when you have a mandate, you create a bunch of bureaucracy that is very hard to change. And sometimes medicine needs to change very quickly, as we've seen during the pandemic. And then the mandates that have happened, of course, there are benefits, but the social harm that they've done without a proper dialogue and the ability to change quickly, we've seen it, we're seeing it now. So I just wanted to address those couple of questions that are in there around sort of mandating training and also legislating. Sorry for the hard work that someone's doing on this. But I'm very much against polarization. And while I'm very outspoken and obnoxious, I don't want to polarize people. I want to have a dialogue with the opposite viewpoint.
Thanks, Sydney. I did see those questions coming in as well. Thanks for speaking to those. I did see a question also about whether the book, a number of questions about whether the book covers certain things. And a lot of the questions that are people asking around whether the book will help them to educate their peers or the people around them in their workplace, the answer is absolutely hands down yes. There is a question about whether we included how our community has been impacted by COVID-19. And the answer to that is a less resounding yes. Just in terms of timing, the final versions of the chapters were submitted to the publisher in and around the time that the pandemic hit. There wasn't really any reliable information at the time. We were able to make some preliminary statements, add in some general statements, and there is a section in particular about how COVID-19 affected sexual health and sexual activity, and feelings of shame in MSM and the broader 2S LGBTQ community. But certainly there's a lot more we could have said, but we would have needed to rewrite the book. So, in line with the idea that things are changing quickly and we want them to continue to change. And, hopefully it won't be too long. It won't be, so 2003 until 2022, hopefully it won't be another, 19 years before the next edition comes out, and we'll absolutely be able to speak to COVID-19, monkeypox, and a lot of the other issues that we're seeing now that we would certainly include if we could have. Does anyone else want to say one last word, one thing that they want the audience to know or to take home from today? I think we're almost ready to turn it back over to Nalini for closing remarks. Did anyone have something burning that they wanted to say before we sign over? Well, I just wanted to abundantly thank everyone on our panel for the discussion today, for contributing not only your expertise, but like really parts of yourself to our conversation today. And I want to thank everybody who has spent the afternoon with us. Thanks for taking the time out of your busy days. I hope that this has been a fruitful and thought-provoking conversation. For me, it's really nice to shift the focus for the day-to-day demands of putting out fires, to reflect on this work that we've done and how we can be involved in moving things forward. And if every participant in this conversation was able to make one small change in their organization, that would just have a massive ripple effect. So let's keep the conversation going. The book and other resources from RHO can definitely be a sort of diving point for making changes in your own practice, in organizations. If you're interested in ordering it, it's available on RHO's website. There's also an electronic version, which is much less expensive and easily searchable, which you can find on the University of Toronto Press website. And with that, I will turn things back over to Nalini for some closing remarks.
Thank you so much, Amy. That was great. This wraps up RHO in Conversation, and you did mention it, but I just want to say, thank you from the bottom of our hearts, because you've shared so much of yourselves, your experience, your perspectives, your knowledge, and it has been extremely heartfelt, inspiring, impactful, and I can't thank you enough for this. I just want to say special thanks, Amy, for moderating this wonderful session. And thanks to all the panelists, Song Zhongwei, Jordan, Ed, Kwan, and Sydney Tam. And I also want to say thanks again to Nicole for opening the event for us. Thank you to everyone who attended this event today. And again, thanks to the RHO staff for putting this wonderful event together, our ASL interpreters, French translators, Lindsay, Tanya, Sonia, for providing such great tech support, and everyone who helped to make this day possible. Thank you. I hope you learned a lot today. I definitely did, and thanks for that. And if you'd like to keep the conversation going, use the hashtag RHO in Convo and tag @RainbowHealthON on Twitter. One last thing, we'd really like to remind you to please fill out the feedback form. You'll receive it via email coming from Eventbrite. And this is very helpful to us in terms of planning future events. So please, fill the feedback form. And as Jordan had mentioned, be sure to check out the learning opportunities that RHO offers through its online courses. So visit rainbowhealthontario.ca to find out more. And finally, thanks to everybody for coming here today. Thank you.